Okay, Bismillahirrahmanirrahim. My name is Dr. Umair Siddiq, and I have been taking these Friday clinicals at DHMC sessions for the past 4 years now. So for you guys, this is going to be the 11th session. So moving forwards, so this is how I look like if we meet without virtually or physically. If we meet physically, you can identify me. I'm a knee and shoulder surgeon working at Doctors Hospital and Medical Center, Lahore, and I'm an assistant professor of orthopedic surgery at Central Park Medical College. This is who I am. I graduated from King Edward Medical University and did my FCPS in trauma and orthopedic, and subsequently in hip and knee replacement surgery, super specialty fellowship. After that, I started teaching postgraduate residents since my passing. I've taught around 100 of residents, and those who have benefited from me, they are all consultants now, and inshallah, one day you all will also be consultants. Why I teach? Because I love teaching. Teaching is my passion, and it has always been. And I consider teaching as sadqa jariya. You have learned knowledge from someone. All of you have learned knowledge from your school teachers, from your college teachers, and subsequently from your university teachers. And someday you have to return it back to your colleagues. So this is how life cycle works, and this is how successful nations are made. This is me leading from the back. You can see me standing at the back, and some of these guys you might be able to identify, some you might not, but alhamdulillah, all of them are consultants now, just like yourself, in a couple of months, inshallah. So my notable contributions to the orthopedic residents are, when I gave the exam, there were no specific local publicated books for our FCPS examination. So I, along with Dr. Mohsin, we published 2 books, one for the MCQs and second for the orthopedic Pearl notes. I've been invited as a national and international faculty in various teaching sessions around the globe. These are my most notable contributions. On the left, you can see Dr. Irfan. He also wrote a book. In the center, Dr. Amir Sohail. His book for MCQs is very popular. And on the right side, Dr. Mohsin Javed, who traveled every week all the way from Islamabad to Lahore just to have my sessions, and subsequently published an orthopedic TOACS and Viva book, and all of them are actively leading teaching activities nowadays. So moving forward to the TOACS orientation. The TOACS orientation specifically talking about the number of stations. So first they had around 15 to 16 stations. Now, if they add 2 rest stations, the total number of stations may exceed up to 17 stations. All of the stations are manned, which means that all the stations are supposed to be interactive sessions. Unless or until they have a shortage of examiners, then they can add a static station. Otherwise, all your stations will be interactive stations. So since you don't have the purpose of rest stations was actually when you keep on writing, you get tired when there were static stations. So they added a few rest stations. But nowadays, as all the stations are interactive or manned, so you don't need to rest between every station. So they have eliminated the rest stations. You will have 4 minutes for each station, but practically speaking, you should prepare for 4 minutes for each station. Because there is a lot of time is lost between when you get up from one station and travel to the next station. And then you settle down, you have to tell your name and roll number, or your roll number or identification card, and 30 or 40 seconds are wasted between this transfer, specifically if the other person is not getting up. So there is a bit of delay. So target your TOACS stations for 4 minutes. When you practice on each other, always keep a watch in your hand and and set a timer of 4 minutes and then start your activity. And after 4 minutes end the activity. This is how much time you are going to get in the exam for TOACS stations. Again, moving on to the subspecialty division, how your TOACS stations are prepared or your TOACS examination is prepared. So one station of counseling is mandatory, is a must. Most likely a neuromuscular disorder will be presented or some other case in which you would be required to do the counseling of that patient. Second station is an instrument station. This is also a must. There is a variety of instruments that can be presented to you, starting from simple 3.5, 4.5 mm small fragment or large fragment sets. You can be asked the principle of lag screw, or how would you fix with eccentric loading of a simple dynamic compression plate, or you can be asked about advanced suture anchors of arthroscopy or total hip replacement or total knee replacement instruments. There is a highly likely chance that shoulder replacement instruments can also be presented in the exam. So kindly be prepared for that. You can watch ample amount of videos on the YouTube, or you can ask your supervisors wherever you are to arrange the instruments for you, so that you can know use and name of all the instruments. Two things are required from you on the instrument station. That is for what it is used, and number two is what is the name of the instruments. Sometimes if the examiner is a bit fishy, he or she might be asking you the spelling of the instruments. So also try to remember that also. Next station is hand station, and the hot favorite topic for hand station is the perilunate dislocations. All of you have a shady knowledge about these dislocations, so and the examiners know it. So most likely they will post a radiograph of a perilunate dislocation, either a acute one or a chronic one, or they can ask that if this is a fresh case, what are you going to do, and if it is a chronic case, how are you going to treat it. So kindly and along with that, the Kindbox disease, its classification is very important. Foot and ankle, moving on to the fourth station, that is a foot and ankle station. So when I gave the talks, on my talks examination, there was a talus fracture with a Hawkins sign positive on the visible on the radiograph. So you can have a calcaneus fracture. The examiner may ask you about the classification of calcaneus fractures. What are the various angles on which you can appreciate a calcaneus fracture? What is the X-ray and the CT guided classification of these fractures? You should know all the, and what are the recent, in all these stations, you should know what are the recent advances, regardless of the fact that your institution is doing it or not. वो आपको ये नहीं कहेंगे कि आप उनको कहोगे मैंने कभी ये देखा नहीं, वो कहेंगे आपने नहीं देखा, आपने पढ़ा भी नहीं. So try to understand this fact. You should know all the recent advances. Moving on to spine station, I had a spine trauma case. You might have a spondylolisthesis or a simple MRI with a disc herniation or a TB spine case. And when a TB spine case comes, you should be able to clearly tell the names, doses of the drugs, and the quantity, how much the anti-tuberculous drugs are given, and the side effects of each drugs. Next is the arthroplasty station. Most likely you are going to get two arthroplasty stations this time. One from the hip and one from the knee. And one of them would be a revision case. So try to grasp your knowledge around of these revision hips and revision knees. As more and more arthroplasties are being done, so a lot of revisions are also in fashion, and you should know how to extract an implant, what are the indications, what are the instruments required to extract an implant, and how to place the next implant. It's very important. Moving on to peds orthopedics. One station would be from peds orthopedics. It can be of SCIF, DDH, or clubfoot. Or sometimes they place a public harness and ask you about its different straps, and indications and complications. Pelvic trauma, the aim or the goal of putting a pelvic trauma case is to ask you about TILES classification, because this is a classification you forget or are confused when actually classifying a fracture on radiograph according to TILES classification. Most of you get confused, so they like your confusion. Don't give them any chance. Secondly, in pelvic trauma, the answer should start from ABC, that is airway, breathing, and circulation. Don't forget, behind every radiograph, there is a human being that you are treating. Moving on to the 9th station, that is the upper limb fractures. Gleazy, Montigia fractures, they are common presentations in the TOACS exam, or humerus chronic osteomyelitis, humerus non-unions. These are the types of X-rays you should expect on a TOACS station of upper limb fractures. And then moving on to the lower limb fractures, you can be asked about Salter-Harris distal femur fractures. When I'll teach about the TOACS station, specifically about the TOACS, I'll show you a few radiographs. They are from the CPSP library, and most likely you'll get some of them in your exam. Moving on to pediatric fractures, the TOACS fracture and the triplane fractures, they're very important. Similarly, the Salter-Harris classification and the treatment options, they will confuse you. They'll give you a Salter-Harris type 2 distal femur fracture, and they'll ask, how would you treat it? So Salter-Harris type 1 and 2 fractures have a very good prognosis. So you'll treat it non-operatively. When you go there, you see a fracture, you try to put in a screw over there, and then they'll ask you, what is the indication of putting a screw over here? You should be able to defend it. If it's a Salter-Harris type 3 or 4 fracture, or the fracture is extending into the joint, then there is a definitive indication of fixation. But reference to Campbell 13th edition, Salter-Harris type 1 and 2 fractures are commonly treated non-operatively. Moving on to sports injuries station, MRI of a ACL injury of knee. So 3 MRIs you should memorize each and every aspect, normal and abnormal. These are the MRI of the knee, MRI of lumbosacral spine, and MRI of shoulder joint. These are the 3 MRIs I'm also going to teach you, but you should first identify what are the normal structures you see in all 3 views, that is the axial, the coronal, and the sagittal views, so that when you see an abnormal thing, you should spot on identify it. Congenital anomalies station, this is also very important station, and you'll be asked about the more common congenital anomalies in this station. Last is the tumor station. So I have, it is very important, I have put it in the last because tumors, basically you tend to forget about the various radiographic features or the treatment options or the investigations required or the signs of these tumors, because there are a lot of tumors and you are expected to memorize each and every one of them. So for tumors, I want you to just make a flow chart on a piece of paper and put it somewhere in your room, so that every day you see that flow chart. This is the only way of memorizing all the tumors, so that you don't make a mistake over there. Next, moving on to the short case orientation. It's very simple and very exhausting. I have seen people sweating in the month of December when giving short cases. So let me tell you this, that if you are not confident enough, regardless of the fact that you have a lot of knowledge and attitude, you're not going to pass this exam. Attitude and confidence matters the most in short cases. You'll have 10 minutes for each station, 5 minutes for your examination, and simultaneous narration. Narrations mean that you are examining and telling the examiner that I have done this, this is positive, this is negative, I have done these special tests, I have done the inspection, and moving so on and so forth. And then you'll have 5 minutes for the Viva with the examiners. You'll face 2 examiners on each short case. One is going to assess your examination and narration, and the second examiner will ask you about what you have examined. Specifically, 3 questions he is going to ask you. Number 1 is, what is your diagnosis? Number 2 is, what further investigations you require in this case? And number 3 is, what is your treatment for this specific patient? So you should prepare your short cases, the important ones, according to these 3 questions. मैंने देखा लोग 2-2, 4-4 घंटे एक ही टॉपिक को डिस्कस करने में, जब आप लोग ग्रुप डिस्कशन करते हो उसमें लग जाते हैं. आपने सिर्फ ये 3 चीजें क्लियर करके नेक्स्ट शॉर्ट केस डिस्कस करना शुरू कर देना, और वो है डायग्नोसिस, रेलेवेंट इन्वेस्टिगेशंस एंड ट्रीटमेंट प्लान. 5 मिनट में इससे ज्यादा आपसे कोई नहीं पूछेगा, और अगर आप ये सही बता दोगे तो आप पास हो जाओगे. जब आप बहुत ज़्यादा डिस्कस करना शुरू हो जाते हैं तो आपके जहन में डिफरेंशियल्स आना शुरू हो जाते हैं, फिर आपके जहन में उनकी रेलेवेंट इन्वेस्टिगेशन आना शुरू हो जाती हैं, फिर आपका ट्रीटमेंट फॉर दैट पेशेंट चेंजेस. सो दिस इज हाउ यू डी ट्रैक. यू शुड नॉट डी ट्रैक. So what types of short cases you are going to get? Foot and ankle, you'll get 2 short cases each. So foot and ankle, you should doubly prepare as compared to the upper limb. ये नहीं हो सकता आपका शॉर्ट केस का एग्जाम और 2 स्टेशंस कम से कम आपको लोअर लिम्ब के ना आए. इसलिए जो जिस तरह के केसेस आते हैं लोअर लिम्ब में, नी भी आ सकता है, नी की एसीएल इंजरीज भी आई हुई हैं, जीनू वेरम, जीनू वैल्गम, द डिफॉर्मिटीज ऑफ द लोअर लिम्ब्स, स्पेसिफिकली स्पीकिंग द फुट एंड एंकल डिफॉर्मिटीज ऑफ पोलियो और सीपी चाइल्ड्स, because they are relatively easy patients to take to the exam and they are not painful enough. Upper limb, you will get 1 short case. It can be either of a brachial plexus injury, complete, incomplete, because they're also cold and young patients. Again, you can get malunited distal radius fractures. These are the cases you see daily in your practice. Spine and hip are very rare in short case. So even if they come in the short case, you will not be able to complete your examination within 5 minutes of spine and hip joint. So the key to success, if you get a spine and hip patient in a short case, is targeted therapy. By targeted therapy, I mean you just pick the positive findings in it and move on. This is how you do when you are in doubt. Always move to the positive findings, because those are the findings on which your Viva is going to proceed. Nobody is going to ask you the range of motion at knee was normal. Everyone is going to ask you where was the fixed flexion deformity. So try to understand this. Then nerve injury stations, deformity stations, the cubitus varus, valgus stations. Similarly, the gunstock deformity, they are very common. The supracondylar fracture in children are very common, leading to gunstock deformities, and examiners tend to have these cases in the short cases. Similarly, the cubitus valgus with tardy ulnar palsy is a very hot favorite case for examination. And on knee station, you can have a genu varus or valgus, unilateral or bilateral deformities, and you can also have a Baker's cyst. So try to do a swelling examination as well. Long case orientation, you'll have 1 long case, fortunately, every one of you, and it would be a 1-hour session. 30 minutes for your examination. In long cases, narration is not required. So you just have to keep quiet and do your examination for the first 30 minutes. A practical point is to limit your examination to 25 minutes. This is the practical amount of time you are going to get in the exam. And this includes history taking and examination, both. So you should tighten your time to 23, 24 minutes maximum when you are practicing before moving to the exam. What types of long cases you get? Most of you will get spine, hip, and knee long cases. Less number of you will get brachial plexus, non-unions, malunions, tumor cases, or CP or polio case. These are the types of cases you are going to get in the long case. So I hope the orientation is clear to all of you. When I passed my written exam, I was in mid-air. I had no idea what to expect in the exam, and I failed in my first examination because I had no book to rely on and to go and prepare from that book, and nobody to teach me. So you should be thankful to your creator that people are teaching you, and you know how many long case and what to prepare and what is the screen in every long case and short case that you have to follow. So you don't have to take the pictures of this presentation. This whole presentation is going to be uploaded on YouTube channel, so you can view it if you have missed something. So these are the list of things you will require for your orthopedic clinical examination. I have put it in this first lecture because I want all of you to make a bag today and complete all these things in your bag, so that when you are doing real examination on the patients, you should know where each and everything is and how to use that thing. I have seen fresh goniometers in the real examination that candidate had not even used the goniometer once during all his training or preparation for the exam. And when you put the goniometer for the first time in your final exam, the examiner knows. So these are the things you should have each and everything. I might have missed one or two things, but I think this is a complete list. So what phases are you going to go through when you are preparing? You have around 2 months and 15 days starting from today for your examination. The final date has not been announced yet, but tentative date is 24 to 29th January. So you have ample amount of time for your preparation. But this is also a drawback because everyone is going to have that time. The only way that you are going to succeed is that you are better than all of them. So when you go on the exam day to give your exam, always think that if one person is going to pass today, that is going to be me. This is the type of confidence and attitude I want all of you from all of you to have when you go for the exam day. So number one phase is scheme development. Take a piece of paper and pencil out, develop your own scheme. Don't rely on the schemes of anyone else. You are the best judge of yourself. You know what are your limitations and what are your positive things. So develop your own scheme. The schedule or the progress of the scheme would be obviously from first introduction, then inspection, then look, feel, move, the special tests, and distal neurovascular structure. But you can alter the scheme according to your limitations and positive findings. So once you have developed the scheme, then you should memorize that scheme. That is the second phase, that is known as scheme rehearsal. And then you should be able to finish that scheme in less than 5 minutes, specifically talking about short cases. If you are unable to finish your scheme in less than 5 minutes, it means you have to shorten your scheme, or you have to cut the normal things and do the tests that are positive in that case. Number 4 is tighter the scheme according to the diagnosis on fake patients or your colleagues. I would suggest all of you to make a group of 3 or maximum 4 colleagues that are working together. That is the best way of passing the exam. Isolated, there are high chances of you to fail because you don't know in how much water you are. You should make a group of 3 or 4 people, like-minded people who are going to do the test on each other. So titrate the scheme according to the diagnosis on fake patients or colleagues. And the next step is then you should move to the real patients. On the first day, don't go to the real patient and start examining the real patients. Now is the time to develop your scheme and titrate your scheme according to the diagnosis on your colleagues. Once you are confident enough that you are completing your schemes in 4 to 5 minutes on your colleagues, then you move to the real patients, because on real patients it is a completely different world. So when you move to the real patients, you should be able to rule in the diagnosis and rule out differential diagnosis, because the first question they're going to ask you when you stop examining is, G doctor, what is your diagnosis? You are going to say, this is my diagnosis. The examiner is going to say, okay, what else can it be? Then you are going to say, it can be this, 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 and this, but I have done the tests for these diagnoses and they are negative. So this is how you progress from developing a diagnosis and ruling out differential diagnosis, so that you should be able to defend your diagnosis. And at the end, you should be able to do this all in under 3 minutes and 30 seconds. This is very important. If you want to take home a single word from today, this is our seventh step over here. That is, at the end, you should be able to do all the examination in under 3 minutes and 30 seconds, because a lot of time is wasted from you by you when you're moving from one station to another station, because you have to put all the things back in your bag that you have taken out for the examination of that specific patient. And again, then you have to move to the next station. And again, the next candidate might be a slower candidate than you, and he might take a lot of time in packing the things, because your Viva is not going to start if the second candidate is standing over there. When the second candidate will move to the next station, then your Viva is going to start, but the time has started. So remember, this is not 5 minutes that everybody tells you that you have 5 minutes for your short case. It is under 3 minutes and 30 seconds. Inshallah, you will be able to complete your examination under 3 minutes and 30 seconds when you have followed all these 6 steps. Try to take these the next 2 weeks, developing the scheme and practicing on your colleagues, not more than 2 weeks, because then you have to move to the real patients. Okay, so next is time management. So time management is one thing. It is the most important aspect which will help you to get through this exam, regardless of how knowledgeable you are in your management. Always remember this. एक पठान वाली घड़ी मिलती है हाथ पे बांधने के लिए ना, वो सब लोग ले लेना। उसमें सिर्फ टाइम और लाइट जलती है, उसकी टाइम नजर आता है, उसमें आपने सिर्फ स्टॉप वॉच लगानी है। एनी एग्जामिनेशन किसी पे भी कर रहे हो, आपने स्टॉप वॉच लगा के एग्जामिन करना। आपने खड़े होकर एग्जामिन नहीं करना शुरू कर देना, या किसी और से नहीं करना टाइमर लगाना, आपने खुद अपना टाइमर लगाना और एग्जामिन करना। सो बाय अ वॉच टुडे, ऑलवेज रिमेंबर दिस। ये मैंने बहुत ज़्यादा लाइक लोग, यानी कि इतने लाइक लोग जिसको आप कहते हो यार ये तो पढ़ता ही रहता है हर टाइम, ये नहीं फेल हो सकता, उनको मैंने फेल होते देखा इस एग्ज़ाम में, सिर्फ वो टाइम मैनेज नहीं कर सके। और मैंने ऐसे लोगों को पास होते देखा जिसको आप लोग भी बाद में कहते हो यार एक दिन नहीं पढ़ा और पास हो गया, वो इस वजह से कि वो टाइम मैनेज कर गया था। क्योंकि जब आप टाइम मैनेज नहीं करोगे तो आप डायग्नोसिस पे ही रुके रहोगे, आप उससे आगे मूव ही नहीं करोगे इन्वेस्टिगेशंस और ट्रीटमेंट पे। या आप योर एग्जामिनेशन, इफ़ योर माइंड माई वर्ड्स, दैट इफ़ योर एग्जामिनेशन इज नॉट कंप्लीट इन द रिक्वायर्ड टाइम, दैट इज फेलियर टू बिगिन विद। जितना मर्जी अच्छा वाइवा दे लोगे वो आपको पास नहीं करेंगे, बिकॉज योर एग्जामिनेशन वाज इनकम्प्लीट। वंस योर एग्जामिनेशन इज इनकम्प्लीट, यू आर अनएबल टू रीच अ डायग्नोसिस and subsequently tell the investigations and treatment of that diagnosis. So always remember that time management is very important. I am focusing a lot of effort in telling you about this, and you might not be able to appreciate it right now, but you in the coming subsequent days, you will inshallah appreciate it and you will manage time inshallah. So Okay, now you can unmute yourself. Let me just choose one. Or who is going to volunteer for test talks? This is just a sample talks, just to tell you how things work. I have 6 minutes left in this meeting. So after this test talks, you can rejoin. That meeting would not be recorded, and I'll ask each one of you what any queries and questions you have. So recorded meeting will end in 6 minutes. You have 5 minutes. Any volunteer should just unmute and tell his name and start. We can start the talks. Any volunteer? Or I am going to improvise then. Okay, Dr. Hafiz. Okay, Dr. Hafiz. Unmute. I'll unmute you. Okay. Okay, Dr. Hafiz, can you hear me?
Yes, sir, I can hear you.
Okay, how are you?
I'm good.
Okay, the environment is very good. So let's start the talk station.
Okay, sir.
Okay, Dr. Hafiz, read the scenario and answer the question number 1.
Describe significant findings. This is a radiograph of a skeletally immature patient, undocumented radiograph showing hip joint with a proximal femur and implant within it, and comminuted fracture of the intertrochanteric region with the screw cut out and broken implant. And
okay, if you are satisfied with your answer, you can move to the next question.
Okay.
Or anything else you want to tell in this radiograph? Dr. Hafiz. Relax, take deep breaths and tell me if there is any significant finding you want to tell.
Sir, there is a collapse of due to most likely due to failure of fixation.
Okay.
Sir, for investigation, I would like to get complete X-ray pelvis, including both hips and proximal femur. And
why, Dr. Hafiz, why do you want a complete pelvis X-ray?
Sir, there may be an pathology on the other side.
Okay, kindly speak up. Kindly speak up. So why don't you want a lateral view of this hip, and why?
Sir, sir, let me complete. Sir, I want lateral radiograph of the involved hip and proximal femur, including AP view of the both hips.
Okay, so what positive finding you are going to get on a lateral view of this radiograph that you are unable to appreciate on an AP view?
Sir, on lateral radiograph, there can be a possibility that the screw is either too anterior or too posterior in the head, which has led to the failure of fixation. And to better appreciate the fracture geometry at the involved site, and to know about more about the thickening of the cortices of the proximal femur.
Okay, any other investigation you require?
I need about the to look for the head of the femur integrity, either presence of subchondral cyst or bone collapse. I may need an MRI, but after the radiographs, I will go for that.
So after radiographs, you're going to MRI in an implant in situ. So would you be able to get an MRI in this metal?
No, sir.
Okay. Any other investigation, or we can move to the next step? Next question.
Sir, I think.
Okay, let's move. We are short in time. How would you treat this case?
Sir, I would take a complete history of the examination.
I'm
Detailed
talking about treatment now, not talking about management.
Sir, I will go for I will get baselines, required radiographs, and will get inflammatory infection markers.
Dr. Hafiz, how are you going to treat? Just tell me, what are you going to do?
Sir, removal of the implant and
Okay. How are you going to remove
application.
this? How are you going to remove this screw? Any
Sir,
instrument required?
Sir, screw sleeve. There is available screw sleeve
Okay, thank
for
you.
screw extractor.
Thank you, Hafiz. Time 5 minutes have finished. Okay, now the take-home message for today's is, these are my quotes. Always remember that there is a human being present behind that radiograph you are describing. Keep watching your watch while examining. All of you will be consultants someday. When that day comes, thank your creator and start spreading your knowledge. Now I'll end this session and you can rejoin again for a non-recorded session, and we'll have an active discussion of question and answers with each and every one of you. I hope you enjoyed it, and I'll see you in the next session.